Hi, my name is Madeline Mumbert. My student ID number is 3251089. My semester is spring of 2020, and my class is veterinary nursing care, course number 2439. To start my video, I'll be demonstrating putting on ECG leads and interpreting my ECG on my machine. To do this, I have a 4-lead machine. Some places have 3 leads, but since we have 4, we need to use all 4. To start, we have our patient in right lateral recumbency. You want your patient right lateral, and you want your restrainer to soothe them. Both of those things will minimize any artifact that could interfere with our interpretation. We're going to put our leads on. There's no specific order, but they all have to be in their specific place. So how I remember it is for the left side, black over red, or smoke over fire. And on the front limbs, you want the leads to be proximal to the elbow. On the back leads, you want them to be proximal to the stifle. And I'm adding alcohol as I go so that it will read through his fur. Okay, once all of our leads are placed, I'm going to turn my CardioPet machine on, and we'll start our ECG. And we'll let it run for a few seconds before we interpret it. Okay, he's good. So when we're looking at our ECG, we're looking at these complexes here. So there's a little hump in, before each line of vertical lines, here, here, and here. Those are the P waves. Those are indicative of atrial depolarization, which is when the atria of the heart are contracting. Then it goes into these vertical lines. This is known as the QRS complex. Q, R at the top, S down here. This is indicative of ventricular depolarization, or when the ventricles of the heart contract. And then last, you have the little hump at the end, like here, here, and here, and those are the T waves, which are indicative of ventricular repolarization, or when the ventricles of the heart relax. So this is kind of your heartbeat in a nutshell. When you're looking at your ECG, it provides you with 2 pieces of information: your patient's heart rate and your patient's heart rhythm. So heart rate, it was pre-calculating a heart rate up here while it was running, but you kind of want to take that with a grain of salt because it counts your R points, and if one of these waves are accidentally a little too high, it might count those also and double count. So it's not perfect, but it is a good estimate if you don't want to count squares, because that's what I'll be doing, is counting squares. I made a little cheat and drew an arrow because here is where 30 boxes end. 30 boxes is equivalent to 6 seconds of runtime. So I'm going to use the 6-second method to calculate a heart rate. So we're going to count the number of R points in 6 seconds. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And you multiply that by 6. And so you get a heart rate of 60 BPM, or 60 beats per minute. And that would be your rough heart rate. Heart rhythm wise, you have to understand if your ECG is reading a regular rhythm, a regular irregular rhythm, an irregular regular rhythm, or an irregular rhythm. Side note, you always want to make sure, if it's a legitimate ECG, that every P wave has a QRS complex, and every QRS complex has a P wave, which our patient does. Back to rhythm, our patient looks like he has a regular pattern, meaning it's completely normal. Some patients will have a long pause occasionally when they take a breath, and that would be known as a sinus arrhythmia, or an irregular pattern. It's irregular because the intervals are not completely equal, but it's in a regular manner, meaning the long pauses are only when they take a breath and not at any other time. So taking a step back and looking at my ECG, I know that my patient has an estimated heart rate of 60 BPM and a regular arrhythmia, or a regular rhythm, no arrhythmia. Okay, quick interruption. I was just watching back that video and I realized that I miscalculated my heart rate. I counted 10 R points and then multiplied by 6 because in my head I was thinking 6-second method and got 60, and that is incorrect. I should have multiplied my R points, which is 10, and multiplied that by 10 to get a heart rate of 100 BPM. So I just wanted to add that in there. I knew you're supposed to multiply by 10, but for whatever reason, I got confused in that moment and miscalculated and misspoke, but the answer should have been 100 BPM. Hi, this is Madeline. Today I will be demonstrating a Schirmer tear test on a dog. This is our patient. Her name is Harley. To do this, I'll break out one of our strips, and we'll just test one eye for the demo, but you want to bend your strip right at the first line. And then we're going to insert this into their bottom eyelid and watch the tear production. It's okay. Maybe me. It's okay. Stay. It's okay. Stay. Good girl. Stay, baby. We'll watch for a minute. Stay. Stay. Girl. Okay, almost done. Stay. 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 Good girl. Stay. Okay. So when you look at it, she stained to the 5 line. So that would technically qualify as KCS or dry eye. Anything that's over the 20 line is normal tear production. Anything between 10 to 15 is like borderline, and then anything under 10 is considered to be dry eye, and you should notify your veterinarian. Hi, this is Madeline. I'll be performing my last ocular test today. It's going to be a fluorescent stain. Harley is back once again. She's being a trooper. To do this, I have pulled up some saline in my syringe. I'm also going to use one of these fluorescent strips here. So what I'm going to do is I'm going to put a couple drops on the end of this, and then I'm going to touch it to her eye. Let the stain take. And the idea is if she has any ulcers or scratches to her cornea, that the stain will absorb to that and it will show up green. So we're going to use our light to look. The green collecting where the tears are is normal, but if you would look in the cornea, you would see a scratch. It would light up green, but I'm not seeing anything. So we're going to flush the eye with some more saline. Get the excess tear out of there. I'm sorry. Flush it one more time. Now that the excess is gone, we'll look one more time.
Y'all have Cindy Harper in room 3.
But still don't see anything. So Harley's eye looks good. No corneal ulcers to note. Hi, this is Madeline. Today I will be demonstrating tonometry on a canine patient. Harley is back as our patient. The first thing we'll want to do is apply some proparacaine to the eye that we're going to be testing. This will numb the eye. We're going to test her right eye.
Good girl. Good girl.
And while that's taking effect, we're going to calibrate our tono pen. So I've added a new little wrap to the end, but what we're going to do is we're going to turn it on. We're going to hold it down. We're going to press twice. It should say cal, and you hold it downwards for about 15 seconds until it tells you to invert it up. So we'll wait for that. Turn it up and it should say good. Okay, so now we can use it. So I'm gonna just lightly press to her cornea a couple times and watch the readings. Anything higher than 20 is considered glaucoma. Stay. It's okay. Stay. Good girl. Good girl. It's okay. Good girl. Stay. Okay, so it read 25, which is higher than you'd expect. That would be considered glaucoma. Hi, this is Madeline. Today we will be demonstrating enema preparation for a dog patient. This is Paxton. He's just here for demonstration purposes, but he does not need an enema today, so we will not be giving him one. To do this, I have a bowl full of soapy, lukewarm water. I have my red rubber catheter, some sterile lube, and then a 60 cc syringe. What I'm going to start by doing is lubricate our catheter. And we're going to lubricate probably the first quarter of this, so we can insert it. And then I'm going to pull out my solution. For a dog this size, we'd probably give about 80 cc's of soapy water and then wait before we give any more. But we're going to attach this. And then I would insert into the rectum. If you meet resistance, you can pull out and then reinsert, and then do that a couple of times until you're fully in. And then you will slowly push your fluid through. And then after this is all the way in, if you have a dog, you can just put them in a kennel. If you have a cat, you can put them in just an empty kennel or a kennel with lots of litter boxes, and hopefully they defecate. And if they don't, you give it maybe an hour and then you redose the same amount. We're going to do the other 20. But it all depends on how long it takes to get the stools malleable and how much stool is actually impacted in the colon. Okay, so after that's given all the way, I would remove the catheter from his rectum and I would let him be free to defecate. Hi, this is Madeline. Today I will be demonstrating administration of subcutaneous fluids or sub-Q fluids. To do this, I have my patient here who has a muzzle on just for safety. And then my supplies are a bag of lactated Ringer's fluids, my fluid line, and then an 18 gauge needle at the end. You want to be sure to change out your needle for each patient. When giving sub-Q fluids, what you want to do is you want to pinch the skin so it's kind of tented, and then you're going to put the needle in that little flap of skin there, so you're going parallel to the body. That way you know you're giving it in the subcutaneous region instead of going into the muscle or a vein by accident. So we're gonna uncap our needle, pinch his skin, and then if you'll just hold it right there. We're gonna open our fluid line. And since we're starting with a full bag, we're gonna give about 100 mils of fluid. So we're gonna go from here, since it's above the one, to this kind of half line there. That would be about 100 mils of fluid. So I'm gonna squeeze the bag so the fluid starts running, and you can already see that there's a little bubble under his skin. For dogs that have tight skin like this, we're gonna give about 100, and then we're gonna pull out, and then I would give the other half of the sub-Q fluids on his other shoulder blade, but we'll just demonstrate this half. And I'll just kind of intermittently check my fluid amount. It's okay, Zeus. It's already getting a little tight, so we might stop our fluids here soon. And it'll eventually disperse over the body, but for the first couple minutes, it just kind of stays in a tight ball. We're about halfway there. You always want somebody restraining for you because it can be a little cold. They'll feel the cold and they might be uncomfortable, so they might become reactive, which is why we have our restrainer and a muzzle on. The general rule of thumb is 100 mils of sub-Q fluids is roughly the size of your closed
I
fist.
had Chester in room 3 for his exam.
Almost there. Okay, so we've made it to that line, so that's 100 mils. So I'm going to close my line so that the fluids stop running. And then when I pull the needle out, I'm going to keep pressure where it was, because a little bit of fluid can sometimes spill out from the hole that we made with the needle. And that's it. Hi, this is Madeline. Today I will be demonstrating how to apply a modified Robert Jones bandage as well as a splint, and then I will remove both of those as well. To do this, I have my patient in lateral recumbency. I'll be bandaging and splinting the left rear leg. My supplies are all laid out here. We have cast padding, brown gauze, vet wrap, white tape, bandage scissors, tongue depressors, a Sharpie, and then our splint last. The first step we're going to do is apply the stirrups. And it's sticky side down on both the lateral and the medial aspect of the leg. We'll put our tongue depressor on as well to keep it from sticking to the other piece. This just helps secure the bandage. Okay, and then I'm going to start with my cast padding. You want to leave the toes exposed. Then we're going to do 50% overlap all the way up the leg. You want to leave the toes exposed so that you can monitor for any swelling, if they're cold to the touch, anything that would indicate that your bandage is too tight. You don't want any wrinkles too, because those could irritate your patient. Take it back some. I'm gonna need a little more. He's got a big leg to work with. Okay. So we've gone just above the stifle, so we'll stop there. And you always want to wrap distal to proximal, so we're going to start again down here. This time we're going in with our brown gauze. And this is going to provide some compression to our bandage. The first layer is mostly just padding. This is the compression. we're doing another 50% overlap as we go up. As a general rule of thumb, you want to leave a little bit of your cast padding showing on both sides. Okay. And then since we need to apply a splint, we'll do that. Actually, first we're going to do our stirrups. So we're going to twist it this way and then sticky side down. Secure our bandage. And then we'll do our splint. Just to secure the splint in place. Do our vet wrap. And I've already pre-rolled the vet wrap out and then rolled it again, so that way I know that I'm not pulling too tight. You just want it to, you want to pull up and then just kind of lay it over relaxed. 50% overlap again. Okay, and so this would be the splint. The toes are still visible, but since we need to do a modified Robert Jones also, I'm going to take the vet wrap off. I'm going to take this layer of gauze off. And we'll remove our splint. Our stirrups are still in place. And then we'll just finish our modified Robert Jones bandage. Need a little more vet wrap. So he'll get two colors. It's okay, Paxton. You're almost in. You're almost in. Okay, so our vet wrap is on. And then to finish, I will put a little piece of tape on our bandage and write the date that it was applied, and then my initials so they know who applied it. Now the bandage is done, we're going to remove the bandage. So we'll take each layer off one at a time. almost done. It's okay. It's okay. Okay, and remove our stirrups last. And that's it. Hi, this is Madeline. Today I will be demonstrating how to apply an abdominal pressure bandage. To do this, I have my patient Paxton, my restrainer, and then all of my materials here. So I have cast padding, rolled gauze, vet wrap, which I've already unrolled and then re-rolled, so it makes it easier when I'm applying the bandage. Tape and a Sharpie to label it at the end, bandage scissors, and then little gauze squares to cover up our wound that he has on his abdomen. But to start, I'm going to place the gauze where his imaginary wound would be on his abdomen. And then I'll start with the cast padding. You want to overlap 50% each time. And we're pulling with a good amount of tension because it's a pressure bandage, but we don't want to pull it too tight to where it constricts the abdomen. And then we'll go in with our rolled gauze. Again, doing the 50% overlap. Okay. And then we'll go in with our vet wrap. And since he's a male dog, you also want to keep in mind to leave room for his penis. And again, I'm pulling with tension because this is a pressure bandage, but you still want him to be comfortable. And these don't stay on for a very long time either, which is the good thing. You want to change these bandages after a maximum of 4 hours. So they're only really useful for 1 to 2 hours anyway. Okay, now that that's on, I'm going to put a little piece of tape on here. And I'm gonna label it with today's date, the time, and my initial, so people know who put the bandage on and what time it needs to come off. And that's it. Hi, this is Madeline. Today I will be demonstrating how to take intraoral dental radiographs on a patient. This is our dog. Her name is Hope. To do this, she is anesthetized, obviously. We have our program pulled up on our machine, and then we have the setting correct for a canine patient, 0.05. To start, I'm going to take my plate, which we've wrapped for our new dog, and I'm going to position it in the mouth with the side of the plate facing me. I'm going to start with our back molars on the right maxilla. Okay, and then we're going to position over the eye. You want this to be parallel with your plate. And then we have our patient information entered into the computer here, so her name is here. Before I shoot, I'm going to select the teeth that I want to take a picture of. And then I'm going to hit this button here, which means it's ready to shoot. I'll hit my button, and I'll announce that I'm taking a radiograph. So I'll say clear or shooting, clear, and then I'll press the button. Okay, there's our first x-ray. So it's got the 2 molars in the back. The roots are visible here. You can see the whole crown of each tooth, and then the pulp cavities are also visible. So now we're going to take our second x-ray. We're just going to move our plate down to our next teeth, and then select our teeth. We're not at the canine yet, we're still doing our molars, and it's still ready to shoot. So we'll take our next x-ray, clear. And that's our second x-ray. The roots are visible on this tooth and the crown is visible here, but this tooth was cut out just a little bit, so I think I'm going to reposition and take one more picture. And angle it outwards a little more so it gets the whole crown of the tooth. Clear. Okay, a little more is visible, but not completely. Let me reposition one more time. Clear. Okay, and the whole crown is there, so if you piece these 3 together, you get a view of the tooth. And then the whole crown of that tooth and half the crown of the next tooth is visible also. Hi, this is Madeline. Today I will be demonstrating hand scaling on our patient's teeth, and then we'll move on to the ultrasonic scaling. To do this, I have my hand tools that I'll go over real quick. We'll use the Ronger forceps first, then we'll go in with our hand scaler, and then our hand curette last. So the dental rongers are mostly used to break up big plaques off the teeth before you go in with your ultrasonic scaler. Get big chunks of plaque off. You want to grab the plaque itself and not the tooth, because you don't want to yank on the tooth, so just stay on one side of the tooth. Okay, that tooth is loose, so I'm going to leave that one alone. And then we're going to go in with the scaler next to kind of break more of that away. We're using it at an angle so that we're not using the sharp tip right onto the enamel. You don't have to get everything because you're going to go in with the ultrasonic scaler, but you want the majority of the plaque scraped off. And then the curette has the more round tip, and that can be used to kind of get under the gum line a little bit too and scrape the tartar out from under there. This is also being used at an angle so that you don't damage the tooth. Okay, and then we'll go in with the ultrasonic scaler next. Okay, now I will be moving on to the ultrasonic cleaning part of the dental. So I'm going to grab my ultrasonic scaler. And when I press on the pedal down here, it'll depress and it will squirt water. And it'll start scaling. So I'm going to use a light foot on this pedal and we'll start scaling the teeth. You want to be at an angle when you do this. You want your contact time to be 10 seconds per tooth. If you still have tartar on that tooth after 10 seconds, just move on to another tooth and come back. Otherwise it heats up the tooth and it can cause damage. Okay, now we have moved on to the dental polishing aspect of our dental cleaning. So I will pick up my instrument and I've put a little bit of prophy paste on the end of a tongue depressor to put on my glove. That way I'm not dipping in and out of the jar, and that way that stays sterile. So I'm going to pick up a little bit of the prophy paste, and then I'm going to use the same pedal to start the instrument, and we're going to work in small circular motions. The reason you polish teeth is because we have created these micro abrasions from our hand scaling and our ultrasonic scaling. And we want to make sure that bacteria doesn't harbor in them, so we'll buff them out. And we've already polished the back side of these teeth when the patient was flipped on the other side. And that's it. Hi, this is Madeline. Today we'll be going over at-home dental care. The best thing to do for your pet's teeth by far is brushing their teeth. And so just to show you how to brush teeth, we have little kits that we sell, and so you don't need anything fancy. You just need a basic toothbrush and then dog-safe toothpaste, so nothing with xylitol in it. The toothpaste can be bought anywhere, but there's different flavors. There's poultry, fish, mint, anything you can think of. So when you're brushing your dog's teeth, you want to take the toothbrush and go up and down on the incisors, and then 1 or 2 strokes on each side for the molars and premolars, and that's it. You don't have to worry about brushing the lingual aspects of the teeth, because when you touch their tongue, it tends to get a bad reflex and they won't want you to do it anymore. And there's usually minimal buildup on these aspects anyway, because that's where their tongue naturally rests. So we encourage that.
I don't have time to brush my dog's teeth.
Okay. If you don't have time, we have different alternatives. One of them would be a daily chew, and this one happens to look like a rawhide, so maybe your dog might like this one.
My dog has allergies.
Okay, there's another alternative. There are vegetable chews. This is an example of one of them, but this way this avoids any animal protein. It's purely vegetables and enzymatic as well.
She's old and doesn't like to chew on stuff, but I also have a cat too that needs dental stuff.
Okay. There are enzymatic additives also that aren't chews. So an example is Perio Support. This is the one that we carry, but it's an enzymatic powder that you sprinkle in their food. So you wouldn't have to have them chew on anything, they would just eat it. There's also a water additive. We carry Aquadent, but we don't have that currently. But that's a water additive, so you can just put it in their fresh drinking water, and you won't have to worry about giving them something and making sure that they consume it. It'll be in their everyday food and water supply.
Okay, so I can just do that on the weekends?
No. The most important thing that you should take away from dental care is that it needs to be done on a daily basis, not just once a week or once a month. Just imagine what our teeth would look like if we brush our teeth that infrequently. It needs to be done daily so that you see the desired effect.